Go ahead.
So, good afternoon, everyone. Today, we are going to discuss on a topic tubal problems and infertility. I am Dr. Gayatri Satpathy. I am a fertility consultant and laparoscopic surgeon. I am working at Oasis Fertility at Bhubaneswar. So, infertility problem is becoming more day by day. Nowadays, every 1 in 7 couples are facing the problem to conceive, and out of the various female infertility causes, if we look at, so there are four important areas where there can be problem generally and which can lead to an infertility. One problem in the female infertility part can be at the level of the ovarian part. So if there are any problems in ovary, for example, if there is anovulation, that is, if there is no ovulation happening in the ovary, which happens generally in conditions like PCOS, or if there are lesser number of eggs present in the ovary because of decreased ovarian reserve, such is seen in patients or elderly women. So there can be ovarian causes for infertility. The second important problem which can happen and can lead to infertility is if there are any diseases or problems which are affecting the fallopian tubes. So today's topic is on tubal factor infertility, and we will be discussing this in greater detail. The third important problem is if there can be any problem in the uterus of the female. For example, if there are any pathologies in the uterus such as like endometrial polyp or any fibroid or adenomyosis, so then there can be infertility problems. And fourth is if there is any problem in the cervix area of the woman. So cervix is the mouth of the uterus, and if there are any problems in the cervix, like any infection or any stenosis or any fibroid, so again the female can have problems in conceiving. So if we look at the various causes of female infertility and how much each problem is contributing to the female infertility, the tubal factor infertility accounts for at least 30 to 35% of the various causes. That means at least 1/3 of the causes of female infertility are because of tubal related problems. So this is what we are going to discuss today in detail regarding tubal factor infertility. And before we come to know what is tubal factor infertility, I think it is very important for us to understand what is actually a normal fallopian tube and what is the function of the fallopian tube for you to better understand what is tube related infertility. So fallopian tubes are two thin, slender tubes which are present on either side of the uterus. So on one end, the fallopian tubes are connected to the uterus, and on the other end, the fallopian tubes are free, and there it is closer to the ovaries. So the parts of the fallopian tube are, the first part is the part of the fallopian tube which is present within the uterus, and it is called as the intramural portion. The second part of the fallopian tube is the portion which is called as the isthmus, and this area is also quite thinner and slender. The third part is the ampulla, which is a more wider part of the fallopian tube, and the fourth part is one which is present towards the free end of the fallopian tube, and it is called as the infundibulum. Now the infundibulum has finger-like projections which are called as fimbriae, and these finger-like projections or the fimbriae, they are more close to the ovaries. So let us now understand the function of the fallopian tube. So every month when an ovary releases the egg, in the process called as ovulation, the egg enters inside the fallopian tube. This entering happens because the fimbriae or the finger-like projections of the fallopian tube are capturing the egg within the fallopian tube. So once it enters into the fallopian tube, then it goes into the portion of the fallopian tube which I explained you is the ampulla, which is the widest part of the fallopian tube. In the ampulla of the fallopian tube, the egg stays for at least 24 hours. So after 24 hours, the egg does not survive. So in this 24 hours, if there is sexual intercourse and the sperm travels to the fallopian tube, it is in the ampulla of the fallopian tube that the sperm and the egg meet and the embryo forms. So once the early embryo forms in the fallopian tube, the embryo stays in the fallopian tube for 3 days. After 3 days, there are small hair-like structures which are present within the fallopian tube which push the embryo towards the uterus. So because the further growth and development of the embryo into a successful fetus and pregnancy can happen only in the uterus. So thus we understood how important a fallopian tube is when we are planning our pregnancy naturally, because it is a fallopian tube which catches the egg. Second, it is a fallopian tube where the egg and sperm actually meet. And third, it is a fallopian tube where the embryo forms, and then the embryo stays in the fallopian tube for 3 days. So when there are any problems in the fallopian tube, any kind of diseases which can cause block or causes inflammation of the fallopian tube, and any problem ultimately not allowing the egg and sperm to meet, or the egg and sperm to meet and form an embryo, or the embryo to successfully go towards the uterus, so then there are problems arising which do not lead to a pregnancy, and this is what is called as a tubal factor infertility. Now, apart from infertility, that is difficulty to conceive when there are problems affecting the fallopian tube, there can be another problem which can happen, which is called as ectopic pregnancy. As I explained you, once the embryo forms, it stays in the fallopian tube for 3 days. But after 3 days, the fallopian tube slowly pushes the embryo towards the uterus, and this pushing happens because there are very fine hair-like strands which are present in the inside of the fallopian tube. But due to any reasons, any condition, if these hairs are destroyed, or that which are called as cilia, if these cilia are destroyed or are defective, then the embryo continues to stay in the fallopian tube and continues to grow as a further pregnancy within the fallopian tube. And any pregnancy, if it grows outside the uterus, is called as an ectopic pregnancy. If detected early, it can be managed medically. However, late detection, or in case the pregnancy progresses and ruptures the tube, then it leads a surgical intervention. Now let us understand what are the different types of fallopian tube damage. So one common fallopian tube damage which we have generally heard is that tubal block. That is, tubal is blocked so that the egg and sperm is not able to meet. But then other than tubal block, there are other problems also which can affect the fallopian tube. For example, salpingitis. Now what is salpingitis? It means infection or inflammation of the fallopian tube, which can happen due to various reasons. Generally, it is because of any past infections or any present infections which has happened in the fallopian tube. The second important disease which can affect the fallopian tube is called as hydrosalpinx. Now, what is hydrosalpinx? Hydrosalpinx is when the one end of the tube gets blocked, so the tube gets distended with any pent-up fluid or blood or sometimes pus, and this fluid-filled tube is called as hydrosalpinx. It can happen because of infections or because of endometriosis. And the third damage which can happen to fallopian tube is because of endometriosis. So coming to the tubal block per se, so there can be different levels in the fallopian tube where the tubal block can happen. So broadly it has been divided into proximal tubal block. So proximal tubal block is defined when the block is in that area of the fallopian tube which is near to the uterus. The second is mid-segment block. So this is the block which is in the area of the fallopian tube which is in the middle part of the fallopian tube. And the third is the distal blockage. So it is the block which has happened in the free end of the fallopian tube. Now, why it is important to classify? Because there can be certain unique causes which because of which these particular blocks have happened, and also the management may also differ depending upon the level of the block in the fallopian tube. Now, what are the various symptoms of black fallopian tubes? Now, you will be surprised to know most of the women do not have any symptoms. They come to us with the problem of infertility, and during routine clinical evaluation, we come to know that there are blocked fallopian tube. The second way is that when the woman has come to with an ectopic pregnancy, that we come to know that there is some pathology associated with the fallopian tube. However, sometimes the patients may have symptoms. Suppose the fallopian tubes are affected due to conditions such as any infections or endometriosis. So then the woman may present with pelvic inflammatory diseases, or patient may have endometriosis, or patient may come with symptoms of sexually transmitted infection. Sometimes patient may come with symptoms of fibroids, etc. Now, if we see the pelvic infection as a cause of tubal infertility, so there are some important pelvic infections which actually lead to tubal infertility. Very common is chlamydia, gonorrhea, and sometimes staphylococcus and streptococcal infections. But in India, it is very important to mention regarding genital tuberculosis, which silently affects the uterus and the tubes and the ovaries. So tuberculosis can cause pus formation, which is called as abscess within the tubes and the ovary. It can cause pus outside the uterus and the tubes in the pelvis area, and then it is called as pelvic abscess, and it can cause adhesions. Adhesions is when something gets attached to something another organ. It is called adhesion. So the tubes and ovaries get attached to each other. They get attached to the uterus. They get attached to the side walls of the pelvis. Then these are called adhesions, and they are a problematic thing because it is distorting. That is, it is changing the normal anatomy of the female pelvis. So thereby the normal ovulation and the meeting of the egg and sperm do not happen as it is supposed to be. The third important problem of the tube, which I had explained, is the hydrosalpinx. Now, hydrosalpinx, so you can see a diagrammatic representation on your left, and on the right, you can see the actual laparoscopic image of a hydrosalpinx. So, when we put a camera, we can directly see how the tubes are swollen and they are enlarged, and they generally contain fluid, and sometimes they may also contain blood or pus. Then endometriosis is a very important reason for tubal factor infertility. Now, endometriosis is what it is, the growing of the endometrial-like tissue. So, endometrium is generally present within the inside of the uterus. But if this inside lining of the uterus grows outside the uterus, then it is called endometriosis. It can affect most of the organs in the pelvis. So fallopian tubes can also get affected. So if these tissues grow in the fallopian tubes may have inflammation, they may get scarred, they may get adhered. They may get adhered, that means they can get attached to the uterus, they may get attached to the ovaries, they may get attached to the pelvis, because of which the normal structure of the fallopian tube gets distorted, the normal tubo-ovarian relationship which should be there, that gets distorted, and natural conception is difficult to happen. And pelvic adhesions. So pelvic adhesions can be because of various reasons. Adhesions can be because of infections. Adhesions can be because of any previous surgery which has happened, or it could be because of endometriosis, or it could be because of tuberculosis. So basically, adhesions is causing a change in the normal anatomy of the tubes and ovaries and causing difficulty in conceiving. And it is important to mention about tubal sterilization because it is also a cause for infertility. But tubal sterilization is done purposefully by a woman when she does not want further pregnancy. So a purposeful block is created by surgery. So the woman cannot conceive. And but sometimes a woman wants to conceive later on after sterilization also, in case she has remarried or she has lost her child of previous pregnancy. So then in such conditions also patients may come to us, and now they are not able to conceive um, because of the purposeful tubal sterilization or the family planning operation which has been done. So these different sites of tubal blockage, which I was mentioning to you, the proximal block, the mid-segment block, and the distal block. So there can be certain unique causes. So they have been differentiated into these categories. The proximal block can be because of conditions like debris or mucus plug. There can be some infections. Mid-segment block is generally because of any previous family planning surgeries or because of surgeries due to ectopic pregnancy. And the distal segment block could be because of infections or endometriosis. So as I explained, most of the times there are no symptoms, but because of the other problems which lead to tubal factor infertility, patients can present to us with pain, she can present with fever, nausea, vomiting, and abnormal vaginal discharge. So now that we have understood broadly what is tubal factor infertility and what are the different types of tubal diseases, now let us understand how do we diagnose tubal factor infertility. Whenever a couple comes to us, it is a tubal evaluation is a part of the routine evaluation which is done for any couple. Why? Because fallopian tubes are playing such an important role for natural conception. So we have to evaluate the fallopian tubes whether they are patent or not. That is, whether they are open or not. So the first line test which is generally done are the tubal patency tests, and these are OPD tests. They are not invasive. That means it is not a surgical test. It's just a daycare or an OPD procedure type of test. Very commonly, we do a test called HSG, which is the full form is hysterosalpingogram. So in this test, a woman is made to lie down, and then a small amount of dye is pushed into her uterus, and simultaneously X-ray is also being taken, and we see whether this dye is coming out from the uterus to the tubes, and then from the tubes it is coming out or not outside. So for example, if you see this particular X-ray picture, it will be more clear. So in this X-ray, you can see that the normal outline of the uterus can be seen. The dye can be seen coming out of both the tubes. And then the spillage of the dye on both the sides can be seen. So once this is seen, it means it's a normal HSG. So the advantages of HSG are, it is not only telling whether both the sides of the tubes are open or not, it is also helping us to understand the uterine anatomy to some extent, whether there is any growth inside the uterus, for example, any fibroid or polyp. Sometimes that also can be visualized in the HSG. Now, how does a tubal blockage appear in an HSG? So, for example, this is a very good HSG for that. Here you can see that the right side, the dye has gone into the fallopian tube and it has come out. But in the left side, the dye has not gone to the fallopian tube. That means probably this woman has got a left side tubal block. And this is an X-ray picture where you can see that both the sides, the uterus can be visualized, but both the sides, the tubes are not visualized. So this is a condition which is called as bilateral tubal block. Now, this is an X-ray picture of a distal tubal block. Why distal? Because you can see that the early part of the fallopian tube can be seen, but the spillage of dye cannot be seen. And the rounded structures which you are seeing on both the sides are hydrosalpinx. That is, the dye has accumulated in this fluid-filled fallopian tube and it has not come out. And so hydrosalpinx also can be diagnosed on HSG. But HSG is a daycare test and OPD test. However, there are certain disadvantages associated with this test. The first important thing is that the pain which is associated with this test, it is cumbersome to the woman. It causes some slight amount of pain. So we give painkillers, we give her relaxants, and pelvic infection risk is also there around 1 to 3%. But most of the times that can be further reduced by giving her appropriate antibiotics after the procedure. Certain women can develop allergy to the contrast media which is injected during the HSG. Then there is a small risk of radiation exposure because HSG is done under X-ray exposure, and then there is a 40% risk that there is a false diagnosis of tubal block. That means, suppose the HSG shows that both the tubes are open, then it means that the tubes are open. But if an HSG shows, suppose 100 women come to me and they say that the tubes are blocked, then out of these 100 women, at least 40 will actually not have a tubal block. It is a false diagnosis which has been made by HSG. And why does this happen? Because HSG is a painful test. Many of the times the woman undergoes spasm and the tubal ends also undergo spasm and the dye does not flow out. So in X-ray, it looks like as if the tubes are open. But when we actually do a laparoscopy to confirm, these women do not have a tubal block and the dye can be freely seen because laparoscopy is done under anesthesia, so it's less painful. So we can actually confirm whether the tubes are open or not. So coming to the second non-invasive test, which is also very commonly done, which I personally prefer to do, is a saline sonogram. So in this test, a small amount of saline is injected into the uterus and simultaneously ultrasound is being done. And we see if this saline is distending the uterus, and so by that we can also see if there is any problem within the uterus, and we also see during the ultrasound whether the saline has come out of the fallopian tubes or not. So this is an ultrasound picture. You can see the black color fluid which is there all around the uterus is because the tubes are open and the fluid has come around. But the disadvantage of this particular procedure is that we cannot conclusively say whether only one tube is open or both the tubes are open or not. So this is one thing. And the other disadvantages is the discomfort. But again, the discomfort is lesser in comparison to the discomfort which happens in HSG. Second is a small risk of pelvic infection. And again, in this also, there can be a false diagnosis of tubal block. So whenever there is a tubal block which is being diagnosed on HSG or SSG, it is always advisable that you should confirm it with a laparoscopy. Now, laparoscopic tubal assessment is 100% confirmatory and it is a gold standard test to diagnose any tubal problem or tubal block. So what are the advantages? First is diagnosis. It is 100% diagnostic. Because woman is under anesthesia, she is pain-free, so she's completely relaxed. There is no spasm of the fallopian tube. So actually there is any problem or not in the fallopian tube that can be detected, and whether the dye freely flows through the fallopian tubes also can be seen. And the second advantage of doing the laparoscopy is the same time treatment. That is, if you have found any pathology, if it can be corrected, we can simultaneously treat it. She does not have to go for a second sitting. So laparoscopic chromoperturbation. So this is the term which is used when we use a colored dye to inject the uterus, and we see on laparoscopy whether this dye is coming out of the fallopian tubes or not. Most of the times we use a methylene blue dye, and it is a blue color dye. As you can see in the picture, the blue color dye can be seen behind the uterus. It is because the dye has passed through the fallopian tubes and now it has accumulated behind the uterus. So that means, okay, the tubes are open or not. Now let us discuss the management part of how do we manage the women who come to us with tubal block. So there are some women who may have only a unilateral tubal block. So this has been confirmed on SSG and if required a laparoscopy. So if there is only a unilateral tubal block, so then most of the times we reassure the woman that even with one tube patent, she has a good chance of getting pregnant. So we can try ovulation induction and we can try intrauterine insemination or IUI. But if a woman has come to us with bilateral tubal block, and this needs to be confirmed with laparoscopy. So if this has happened, so how we are going to manage the tubal block depends on various other factors. First is, what is the site of the block? Is it a proximal block? Is it a mid-segment block or a distal block? Second, if there is any hydrosalpinx present, and also management of tubal factor infertility depends on the male partner also, whether there is any abnormality in the male partner semen or if there is any sexual dysfunction. It also depends upon the age of the female partner, and also very important, whether the couple wants to go ahead with any kind of laparoscopic surgery for the tubal problem or straight away want to go for IVF. Now let us understand how we manage a proximal tubal block. Now again, I'll just repeat the thing. What is proximal tubal block? So any block which is in the portion of the fallopian tube that is near to the uterus. So that is called as proximal tubal block. So how do we manage it? So it is done by a procedure which is called as hysteroscopic tubal cannulation, and it is done most of the times under laparoscopic guidance. So what we do is we put a small camera inside the uterus, and this is called as hysteroscopy. When we put a camera in the uterus and we are able to directly see the inside of the walls of the uterus, we are able to see where the opening of the fallopian tube is within the uterus. So once the opening is visualized, we put a small stent or a cannula inside this opening, and we try to release any debris or mucus plug which has blocked the tube in this area. So this is called as tubal cannulation, and 40 to 50% of the times we are able to release these debris. And once the cannulation is done, and next we push the dye, under laparoscopy, we are able to see the free flow of dye from the tubes. Now, next is how do you manage distal tubal block? So, distal tubal block is most of the times because of infections, because of which the fimbriae, which are the finger-like projections at the free end of the fallopian tube, they get adhered to each other. That is, they get attached to or stick to each other. So, if we try to release this fimbriae, try to make a new opening within this fimbriae. So, these procedures are called as fimbriolysis or fimbrioplasty, neosalpingostomy. So we try to create another good anatomy of the distal part of the fallopian tube so that it is able to capture the egg which is released from the ovary well and do the subsequent functions well. So this is also done under laparoscopic guidance. And once the procedure is done, again we put a push dye through the uterus and check whether that dye has come out or not. But if the distal block is associated with hydrosalpinx, then it is preferable not to create a new opening for the tube in the free end. It is better to get rid of the tube or disconnect this tube with the uterus. Why so? Because the fluid which is present within these dilated fallopian tubes or the fluid which is present within these hydrosalpinx is most of the times embryotoxic. So, if we leave the hydrosalpinx as it is and woman tries to conceive either naturally or with IVF, the chances of her miscarriage are increased. The chances of her not getting pregnant is also increased because this is an embryotoxic fluid. So, it is important that we disconnect this fluid entering into the uterus. So, either we can put a clip in the region between the tubes and the uterus, or we can completely remove the tube if the tube is very badly damaged or if it's in a very bad state. So either clip. So this procedure also can be done by laparoscopy. So laparoscopic tubal clipping can be done, or salpingectomy can be done for hydrosalpinx, and it is a recommended treatment for hydrosalpinx. This improves the chance of success with IVF and also reduces the rates of miscarriage. The other treatment which can be offered to patients with tubal factor infertility due to pelvic adhesions, as explained earlier. So this is laparoscopic adhesiolysis. So whereby these adhesions, those areas where it is stuck to abnormal areas, so that adhesions are cut down either using scissor or we can use energy sources like bipolar correlation and cut or harmonic scalpel. So these are cut, and what the basic aim of doing an adhesiolysis procedure is that we are trying to restore a normal anatomy within the pelvis so that the chances of natural conception is maximized. So here in this picture, you can see we are using scissors and we are trying to cut down the adhesions which are present between the tubes and the uterus. And the another procedure which is also done for patients who have underwent sterilization in the past and now want another pregnancy is sterilization reversal. Again, this also can be done under laparoscopy, but because tubes are very fine structures, so it requires microsurgical techniques to reconnect both the fallopian tubes. So this is how it looks in laparoscopy. In the left side, you can see that the tubes are disconnected, but in the right, so those two ends have been freshened up, and again they have been closed together using sutures. But in which category of patients this sterilization reversal is useful? So not in all women we will advise to go for sterilization reversal. Particularly if she's a young woman, she has a very good ovarian reserve, her male partner has a good semen good semen count, and there are no sexual dysfunction. And on laparoscopy, we feel that the tube looks absolutely normal, and the final length of the fallopian tube that can be achieved after sterilization reversal is at least 4 centimeter, then these are ideal candidates who should go for sterilization reversal, and then they have very high chances of conceiving naturally. Now, coming to the last management part of tubal factor infertility, again, IVF is again one of the most important treatment for tubal factor infertility. But in whom should we go for IVF? So, women who are advanced age, that is particularly if they are more than 35 years. Second, women have decreased ovarian reserve. So, if the number of eggs in her ovaries are less, that her chances of natural conception are low, then it is better that they go for IVF. Then, if the woman has a male partner who has an abnormality in his semen or there is any sexual dysfunction, then the chances of natural conception are low. So, it is then better to go for directly an IVF. Or those women who have tried tubal reconstructive surgery laparoscopically, but since 1 year they have tried and they have not been able to get pregnant. So, in that case, IVF is the best treatment to go ahead. Or those women who have very badly damaged tube, extensive tubal damage, or they have big hydrosalpinx, or they underwent surgery for hydrosalpinx like clipping or salpingectomy. So those women should go for an IVF. So the good thing is that women who have problems related to the tube, but other things are generally normal, like they have a sufficient ovarian reserve, the semen parameter is normal, uterus is fine, and only the tubal part is a major problem, then these women generally have very good success rates with IVF. So to conclude, fallopian tube problem is one of the most common reasons, like around 35% or one third of the causes of female infertility is because of the fallopian tube related problem. And second, there are many diagnostic methods available. We have simple OPD daycare tests available like hysterosalpingogram or saline sonogram or hypo-C tests available. And we have also 100% confirmatory tests available such as laparoscopic surgeries. And but what management needs to be done depends on various factors. What findings we have got on the imaging, whether it is a proximal block or a mid-segment block or a distal block, whether any hydrosalpinx is present. Third, the what is regarding the couple, what is the age of the female partner, what is her ovarian reserve, what is the male partner's semen analysis, is any sexual dysfunction present. So depending on all these factors, a personalized treatment is given, and we decide whether the couple will benefit from tubal reconstructive surgery or the couple will benefit from IVF. And so I hope this was a very important topic which we have discussed today, the tubal factor infertility. I hope I was able to give you some idea about the various causes of tubal factor infertility and how what are the various reasons for these tubal factor infertility, how do we diagnose and how do we manage them. I shall be very happy to answer any questions if present from the audience. Thank you. Yeah, so if there are any questions, please, I would be very happy to answer them. So the first question which has been asked is, what is the main cause of tubal infertility? So in India, the main cause of tubal infertility is pelvic infections. Most of the time, these women have had pelvic infections in maybe in their adolescence or in the growing up years. Many of the times, these infections do not come up with any symptoms. So the woman may not even know that she had had pelvic infections in the past. And only when she comes to us and during her evaluation that we come to know that there is any problem in the fallopian tube, we come to know that there is tubal infertility. So the most common cause is infections followed by any surgery or endometriosis. So, what are the signs of blocked fallopian tube? So, as I mentioned, if you ask me symptoms, most of the times there are no symptoms. A female comes to us because she is not able to conceive, and only during the investigations we come to know that there is a blockage. Or there can be, or she may come to us with ectopic pregnancy, but most of the times there are no symptoms. And if you ask the signs, so in HSG, if we see that the dye has not come out, or in saline sonogram, we are seeing that the saline has not come out of the fallopian tube, then that only suggests. And to confirm whether she has a blockage or not, we can do a laparoscopy and we can 100% confirm whether the problem is there, whether there is any tubal related problems. So what is the best way to unblock fallopian tube? So again, the best way depends upon which area of the fallopian tube the blockage is present. If the blockage is in the proximal part, that is the part which is near the uterus, so then we can go for a cannulation, hysteroscopic tubal cannulation. A small guide wire is put or a cannula is put from the uterus and towards the fallopian tubes, and we try to open the fallopian tube. If it is in the middle part of the fallopian tube, so that particular area need to be cut and the two ends need to be rejoined again. If the distal part of the fallopian tube is damaged, as I explained you, laparoscopic surgeries are available whereby we can make a new opening in the fallopian tube so that it can perform its function. These are the different ways we try to unblock the fallopian tube. And how do we check that the surgery has been done successfully? So once the surgeries, appropriate surgeries has been done, depending upon whichever level it is, at the end of the procedure, we push a small amount of dye, and then we see whether this dye has actually come out of the fallopian tube and whether our surgery has been done well or not. So can you unblock tubes without surgery? So without surgery, it is very difficult to unblock the tube. Yes, in case if it's a proximal tube block and we are suspecting that there could be any mucus plugs or debris. So sometimes forced pushing of saline or forced pushing of dye within the uterus may sometimes release these plugs and debris, so it may open up. But if there is extensive tubal damage, because of which there is tubal block, so then you require a surgery. But most of the, and in case the tubal damage is very severe, even surgery will not be able to unblock the fallopian tubes, and then you need to go for IVF. So basically, the thing depends is what is the severity of the tubal thing. If it's a very mild, maybe a simple flushing of the fallopian tubes using various saline or dye, maybe that will help. But as the severity of the condition increases, initial part can be taken care by surgery, but the later part you may require an IVF. Can tubal blockage be fixed? Yes, Mary. That is why it is important to diagnose if there is a problem or not. So to confirm, when we are doing a laparoscopy, to confirm whether the tubal blockage is there or not. So depending upon the condition of the tube, in the same setting, we can even try to rectify it. As I mentioned, we can do a cannulation. 40 to 50% of the women may benefit. In case of distal tubal problem, we can try to again create a new opening. We can try to release the adhesions in the fimbria. Suppose the tubes are fixed to different parts like addition because of adhesions, we can do adhesiolysis. That also can sometimes reverse the tubal blockage. So 40 to 50% of the women can benefit from surgery. So that is why it is advised to the women. Yeah, I think so. Most of our questions have been answered. In case there is any unanswered question which you get after when you see this video later on, you can always put it in the comment section, and I would be happy to answer them. Thank you so much.